Zepbound, Tirzepatide, has a second hormone signal that Wegovy, Semaglutide, does not. Wegovy activates one major appetite pathway, while Zepbound activates that pathway, plus another hormone target. That extra target helps explain why Zepbound produced greater average weight loss in a direct trial. It does not guarantee that Zepbound will work better for every person. The difference changes hunger, calorie intake, and blood sugar control. Both drugs copy gut signals released after eating. One is glucagon-like peptide 1, called GLP-1. It tells the brain when enough food has arrived. It slows early stomach emptying and helps release insulin when blood sugar rises. Wegovy activates the receptor for this hormone. Zepbound also activates the receptor for glucose-dependent insulinotropic polypeptide, known as GIP. This second gut signal helps insulin release after meals. GIP receptors also sit in appetite-related brain regions. Zepbound combines both receptor actions in one drug molecule, not two separate hormones. Wegovy reduces hunger by strengthening that first hormone signal. Many people feel full sooner, think about food less often, and stop meals earlier. Early stomach slowing can add fullness, but that effect weakens over time. Long-term weight loss depends more on lower calorie intake than permanently delayed digestion. Zepbound keeps that signal and adds GIP receptor activity. The two signals overlap, but they are not identical. Together, they may affect appetite systems in the brain and pancreas more broadly than one signal alone. Animal studies support a brain effect, but GIP's exact human role remains partly unresolved. The drugs also have overlapping effects on blood sugar. Both increase insulin release when glucose is high and reduce an opposing hormone called glucagon. Used alone, they usually have a low risk of severe low blood sugar. That risk rises with insulin or diabetes pills. Two receptor targets do not mean twice the effect. Both pathways touch appetite and insulin, so some work overlaps. How strongly Zepbound activates each target matters more than counting targets. It is not Wegovy with an extra ingredient. The GIP story also overturned an older assumption. Natural GIP helps the body handle and store nutrients after eating. That led some researchers to suspect that activating its receptor might worsen obesity, yet activating both signals produced major weight loss, showing that a natural hormone's job cannot predict the drug's full effect. A direct trial showed the practical difference. Adults with obesity, but without diabetes, received the highest tolerated dose of either drug for 72 weeks. Average weight loss was 20.2% with Zepbound and 13.7% with Wegovy. For a 250-pound person, those averages equal about 51 pounds versus 34 pounds. Those numbers describe groups, not promises. The trial included 751 adults with doses adjusted for tolerance. Some people lost far more, while others lost much less. It also excluded diabetes, so the result does not perfectly predict weight loss in someone with type 2 diabetes. Dose comparison needs caution. The trial tested Zepbound up to 15 milligrams and Wegovy up to 2.4 milligrams. Those numbers cannot be compared directly because each drug has different strength and activity at each target. The study also did not test the newer 7.2 milligram Wegovy injection. The trial showed an average difference. It did not prove that the second hormone alone caused every extra pound lost. Dose strength, target effects, side effect tolerance, and continued treatment all contributed. The biology explains why a difference is possible, while the trial measures the drug effect. A two-target drug can still be the wrong choice for one person. The number of targets does not predict which drug will work better for you. Someone who cannot tolerate Zepbound may lose more on Wegovy. Someone with weak appetite control on Wegovy may respond strongly after changing drugs. Consider two people who start at the same weight. One reaches a useful Zepbound dose, but develops persistent vomiting and repeatedly stops treatment. The other tolerates Wegovy, takes every dose, and steadily eats less. The supposedly weaker drug can produce the better real-world result. That real-world gap often comes down to side effects. Nausea, diarrhea, constipation, abdominal discomfort, and vomiting are common during dose increases. Zepbound does not automatically cause more symptoms because it has another target. In the direct trial, stomach and bowel problems stop treatment more often with Wegovy. Tolerance determines whether a response can last. Mild nausea may be manageable, but repeated vomiting, dehydration, severe pain, or inability to eat is different. A powerful dose is useless when it cannot be continued. Slower dose increases can sometimes preserve treatment without forcing the highest dose. What matters next is the response you can sustain at a stable dose. Look at weight change, waist change, hunger, food thoughts, and side effects together. A useful review often uses an 8 to 12-week trend at a tolerable dose. Judging during the first starter doses can label an effective drug as a failure. Weight alone can hide an important response. A smaller waist, better portion control, and fewer uncontrolled eating episodes may appear before another large drop on the scale. However, unchanged weight and unchanged appetite after adequate treatment deserve review. Simply waiting longer without checking the dose or plan wastes time. The quality of that weight loss matters too. As body weight falls, both fat and some lean tissue, including muscle, may be lost. Older adults and people eating very little should track protein intake, muscle strength, and strength exercises. The goal is healthier weight loss, not the smallest possible number on the scale. That review should not start with one bad week. Salt, constipation, travel, and menstrual changes can hide fat loss on the scale. Within the longer review, use a 4-week trend and waist measurements to separate a real plateau from daily noise. Medical goals also change the choice. Wegovy has an approved use for reducing major heart events in certain adults with established heart disease. Zepbound has an approved use for moderate to severe obstructive sleep apnea, repeated breathing pauses during sleep, in adults with obesity. Those specific goals may outweigh average weight loss differences. Access can still overturn that choice. A drug that disappears after 1 month because coverage fails cannot deliver a 72-week result. Compare the copay, supply, insurer approval rules, and whether you can keep getting the drug. Reliable access often beats a theoretically stronger drug that you cannot keep taking. Before switching, identify why the current drug seems weak. Missed doses, untreated sleep apnea, liquid calories, binge eating, and weight-promoting medicines can blunt progress. Fixing one of those barriers may restore weight loss. A different injection cannot fix an untreated barrier. When response, tolerance, or access leads to a switch, do not use both drugs together because they share GLP-1 activity. A clinician should choose timing and starting dose based on the previous dose and side effects. Starting too aggressively can cause severe nausea or vomiting. Overall, Zepbound produced a stronger average result over 72 weeks. It also acts on a second hormone target, but that does not make it a universal upgrade. Wegovy can still be better when response, tolerance, its heart benefit, or dependable access favors it. Choose using evidence from your own treatment results. Reach a tolerable dose, track hunger and weight, review side effects, and match the drug to the medical goal. The best option is not the pen with more receptor targets. It is the treatment that produces meaningful benefit and can be continued safely. Medicine, simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.